Okay, go
All right.
ahead.
All right. So I'll be presenting question 2A today. So the question goes, a 60-year-old man presents with a 2 days history of dysphagia, a day history of shortness of breath and lip swelling. He's on medications for hypertension, pain, and prostate cancer. He had an antihypertensive added to his medication prior to onset, and then a picture of a swollen lip was shown. So question A is, what is the diagnosis? Question B says mention 4 classes of drugs associated with this diagnosis, and C is discuss step-by-step management of your diagnosis. So my diagnosis is drug-induced angioedema, most likely from ACE inhibitors. B, and then the mentioned 5 classes of drugs, or is it 4 classes of drugs that can cause it? First will be ACE inhibitors. Examples will be lisinopril and enalapril. And 2 will be angiotensin receptor blockers, e.g. losartan and valsartan. They're much less common, but possible. Then you can also have NSAIDs, which ibuprofen and naproxen, and then calcium channel blockers are very rare but possible. And then certain antibiotics like penicillin can also cause drug-induced angioedema. So step-by-step management of angioedema is immediate assessment. The most important thing is to secure the airway, because angioedema can cause swelling of the soft tissues, dermis, and then it can compromise the larynx too. So you have to assess the airway for compromise. If there's any indication for airway obstruction or respiratory distress, prepare for emergency intubation or tracheostomy, which may be required. Number 2 is to discontinue the offending drug. Stop the ACE inhibitor or any other suspected drug immediately. And then pharmacological treatment. You have to give your antihistamine, diphenhydramine or ranitidine, to reduce the histamine-mediated component of angioedema. And I'll explain this later because there are 2 types of mediated. So for histamine-mediated, you can give them the antihistamine. You give your steroids, administer intravenous corticosteroid, either methylprednisolone or hydrocortisone, and then epinephrine in cases of severe angioedema with anaphylaxis or significant respiratory compromise. Administer intramuscular epinephrine. And then sometimes you can give FFP, icabitant, or C1 esterase inhibitor, and I'll explain why later. So this is just the same thing that I mentioned before. Discontinue ACE, administer oxygen if required. Epinephrine should be 1 in 1,000, 0.3 to 0.5 ml. Your corticosteroids, your FFP, and consider prophylactic intubation if airway is compromised. And field intubation is an indication for tracheostomy. So basically, angioedema is a localized, non-pitting swelling of the deep layers of the skin or mucous membranes. So it's important to know that it's localized and is non-pitting. And then it's caused by increased permeability of blood vessels, leading to leakage of fluid into the surrounding tissue. The swelling often affects the face, lips, tongue, throat, and less commonly other areas of the extremities or the gastrointestinal tract. Patients would usually complain of abdominal pain, severe abdominal pain, because there's also swelling of the guts. So you have to you have to put that into consideration. So drug-induced angioedema can be broadly categorized into 2 types based on the underlying mediator. So you have the bradykinin-mediated angioedema. So the mechanism basically is bradykinin is a potent vasodilator that increases vascular permeability, leading to fluid extravasation and swelling. And unlike histamine-mediated angioedema, the bradykinin-mediated angioedema does not involve mast cells or basophils, and it typically lacks urticaria, often hive seen. So basically, when patients come with bradykinin-mediated angioedema, they're not going to complain of itching or complaining of hives or urticaria. And usually the swelling is asymmetric. You see one part of the lip is swollen, or the lower part of the lip is swollen and the upper part is not swollen. Next slide, please. So is this an example? You can see the upper lip is fine and the lower lip is quite swollen. So this is usually bradykinin, and bradykinin is seen usually in ACE inhibitors and ARBs, unlike histamine, which you see with NSAIDs and other allergic reactions. So risk factors for angioedema, especially drug-induced, is age greater than 65 years of age, female. Other risk factors would be African American, but I wrote Black here, smoking, and concurrent medications with either NSAIDs or calcium channel blockers with ARB or with ACE inhibitors. So I just wanted to go over this diagram to explain the bradykinin mediated angioedema. So basically, bradykinin plays an important role in inflammation and is a product of the kallikrein pathway, basically. So basically, the kallikrein is important for conversion of factor 10 into factor 10A in the intrinsic pathway, and bradykinin is one of the byproducts for that. So, and you can see from the side is that basically, usually ACE, which is angiotensin converting enzyme, would degrade bradykinin. But if you're on ACE inhibitors, you inhibit the ACE and then you have buildup of bradykinin. And usually most people are able to keep the bradykinin levels at bay, even if they're on ACE inhibitors. But however, some other people are not able to clear the bradykinin, so they have buildup of bradykinin. And sorry, I forgot to mention earlier, about 0.3 to 0.7% of people would have ACE-induced angioedema. That sounds like a very small number. However, if you consider the amount of people that are on antihypertensive, especially ACE inhibitors, then that will be a very huge number of people coming to the emergency department with ACE-induced angioedema. So basically, you have buildup of your bradykinin, and as I mentioned earlier, is a potent vasodilator like prostaglandins, and then it causes localized swelling and is a potent vasodilator, basically. So that's what causes ACE in some ACE inhibitor angioedema in some people. As you can see at the bottom, I wrote vasodilatation, increased permeability, and edema. Thank you. So next slide, please. So for histamine-mediated angioedema, it occurs when an allergen triggers the release of histamines and other inflammatory mediators from mast cells and basophils. And this leads to vasodilatation, increased vascular permeability, and classic symptoms of edema. Triggers in this type of angioedema is NSAIDs, antibiotics, and certain vaccines. And then with this, you can have anaphylaxis. With histamine-mediated angioedema can also be part of anaphylaxis, which is severe systemic allergic reaction. Next slide, please. So just side-by-side comparisons. With histamine is rapid, often within minutes to hours, because it's a type 1 hypersensitivity reaction, where bradykinin is slower, often hours to days. And if you remember the question, it said the dysphagia came like a day or two before the swelling. So, and usually histamine is associated with anaphylaxis, and bradykinin-mediated angioedema is not. There's presence of urticaria in histamine. There's none in bradykinin-mediated angioedema. Mechanism, as I mentioned earlier, with histamine is allergic reaction with mast cell and basophil activation and histamine release. And then with bradykinin, it's just bradykinin accumulation leading to increased vascular permeability. So this is response to epinephrine, histamine, and steroids. So histamine-mediated has a very good response to that, often resolves with treatment. But the bradykinin-mediated angioedema has a poor response, often persists despite treatment. And as I mentioned earlier, when I was answering the question, then I said you can give them steroids, antihistamine, and epinephrine. That is usually done for both type of angioedema. However, most times with bradykinin-mediated angioedema, the symptoms might persist. So you might have to give them other things. And then the last says NSAIDs, the causes of both. Next slide, please. So for the bradykinin-mediated angioedema, as I mentioned, you discontinue the offending drug, and then you might have to give C1 esterase inhibitors. Okay, sorry, I just have 2 more slides. You might have to give them C1 esterase inhibitors, even though this is the management for hereditary angioedema. it is the same, even in hereditary angioedema, it is the same accumulation of bradykinin. So you may have to give them that, even though they said even in some people it still persists. If you give them C1 esterase inhibitors, it may work in bradykinin-mediated angioedema. Then there's a drug called icatibant. It's a bradykinin receptor antagonist, which is specifically used for hereditary angioedema, and it might be effective in patients with ACE inhibitor-induced angioedema. You can also give them FFP, and FFP would be the most likely treatment in this because it is cheap and it is readily available as compared to icatibant. It contains enzymes that break down bradykinin, and then supportive care you can still treat as you treat histamine mediated angioedema. Next slide, please. So for histamine-mediated angioedema, you'll use your epinephrine, your antihistamine, your corticosteroids, and your supportive care in management. The next slide. So I just wanted to do a slide or two on hereditary angioedema just to wrap up the whole angioedema. So hereditary angioedema is a rare genetic disorder caused by deficiency or dysfunction of the C1 esterase inhibitor, leading to uncontrolled bradykinin production. And inheritance is usually in the autosomal dominant pattern. So the lack of functional C1 esterase inhibitor results in excessive bradykinin, causing increased vascular permeability and recurrent episodes of severe and localized swelling. So symptoms, as you remember, I said is recurrent and they don't complain of pruritus, they don't have hives of urticaria, but they have non-patent swelling of the lips. So it's very similar to ACE inhibitor angioedema. Next slide, please. So triggers is physical trauma, stress, infections, and certain medications like ACE inhibitors. You can even have it without any clear trigger. So diagnosis is low levels of C4 complement and low levels of the C1 INH. So you check for quantitative and functional in blood tests. And the reason why this is important is because C1 esterase deficiency is a complement regulatory protein deficiency. C1 esterase is a potent inhibitor. It inhibits the complement pathway to prevent spontaneous activation of the complement system. So basically, it checks the complement system. And if you have deficiency of it, you have unchecked activation of C1, C2, and C4 complement pathways. So basically, it checks the pathway. And if you have lack of it, you have unchecked activation. Next slide, please. So treatment, as I mentioned earlier, you give them bradykinin receptor antagonists. You also have your kallikrein inhibitor. And then long-term prophylaxis, you can use androgens like ladanazole, antifibrinolytics, and then you avoid triggers, especially ACE inhibitors in this patient. I have to mention that these drugs are very, very expensive. So you have to be very, you can use your FFP, even though they are more effective, but they're not readily available. But you don't treat hereditary angioedema as you treat histamine-mediated angioedema. Thank you very much.
Thank you so much, Dr. Aliyu, for that beautiful presentation. It was very lucid and concise. Okay, so we'll take comments and questions from the participant first, and then let's keep the thanks coming on the chat. All right, I can't see any hands up yet. Okay, let me, I want to just share a few thoughts of mine, but I stand to be corrected.
Okay, go on,
where there is. Okay, so the histamine-mediated, I think it can also be called an allergic angioedema, and then the bradykinin-mediated can be called a non-allergic angioedema.
Yes.
And then for the allergic, other causes include beta-lactams, even quinolones, iodinated contrast media, some even pollen, some foods, insect venom, and then they require a prior exposure for the angioedema present, but for the bradykinin mediated, even the first exposure can cause it, like for the ACI specifically, said it could occur on the first day or maybe a week or even up to a year
Yes, yes,
after the
yes.
exposure.
Sorry, I
And
forgot to mention that you can be on ACE inhibitors for years, and then just one day you can have the angioedema with bradykinin mediated. But for histamine is type 1 hypersensitivity, so you need a prior exposure, and then the second time it happens, and then it can come with anaphylaxis. That's the histamine mediated. Thank you very much. I forgot to mention that. Yeah.
okay, and then to also add to the pathophysiology, said the ACI usually will break down bradykinin, but when you're given the inhibitor, that effect is inhibited. But there are other enzymes that now take over, like the amino peptidase P and dipeptidyl peptidase 4. So they become responsible for degrading. So when these other alternative enzymes are disrupted, then the patient will come down with the angioedema.
Okay.
Okay.
Yeah. Thank you.
Thank you.
Thank you very
Okay,
much.
so we have okay, so a lot of thanks to you, Dr. Liu. Thanks. Dr. Becky, Dr. Araga, Dr. Elohim says, thanks for the lucid presentation. What is it? Would you want to comment on that first? Or do I take all?
Sorry, you went off for a second, so I didn't hear what you said.
Okay. Hello, can you hear me now?
Yeah, I can hear you. I can hear you.
Okay, so Dr. Yusuf Rahim says, thanks for the lucid presentation. What is the difference between urticaria and angioedema? Hello, did you hear me?
Hello?
Oh. Can you hear me?
Yeah, I can hear you.
Okay, should I take all the comments before you?
No, I can just answer this. Yeah. So basically, urticaria is characterized by
so what's the
yeah, so they're very itchy wheals or hives with or without surrounding erythema flare. So basically, urticaria will be on the skin. It is itchy. They're basically, maybe a dermatologist can help me here, but they're usually on the skin and they're itchy. And then with your angioedema, it will be, as I mentioned, is swelling of the dermis subcutaneous tissue. And usually you see it on the face or the lips, but with urticaria, you see it on the skin. And they're itchy and they're like wheals or hives, as you may call them.
All right, thank you so much. Okay, so maybe okay, let me just take all the comments on the chat so you can take them together.
Okay.
And you just stay with me in the chat. Okay, so Dr. Andrew Godia says, thank you so much for the presentation. We can also use tranexamic acid in ACI-induced angioedema. It is also known as Quincke's edema. Thank you, Dr. Godia. Then Dr. Yahya says, thank you, Dr. Farida. It's a good one. Other drug causes are DPP4 inhibitors, okay?
Okay.
Renin inhibitors. If medical therapy fails or severe airway compromise, you may need to do tracheostomy. Management of severe cases, patients should be admitted directly to the ICU. It's a good one, Dr. Farida. Thank you so much, Dr. Yahya. So you just take note and add. Dr. Justice says, thanks so much for a great presentation. I think we should clearly mention the option of ARBs in these patients since they don't inhibit bradykinin degradation. All right, thank you, Dr. Justice. Dr. Rita says thanks. Dr. Justice also adds, then the multidisciplinary care as well should be emphasized. Okay, so you just add that.
All right, I'll do that.
Aden, thank you so much for the presentation. We can also use, okay, no, I've taken that one. All right, then the other says thanks. Okay, so there's a hand up. Okay, Dr. Temi, please go ahead.
Okay, good morning, teachers. Good morning, everyone. Thank you, Dr. Farida, for a very, very clear discussion. I just wanted to add, in case the question comes in another form, that for both forms of angioedema, whether it's histamine or bradykinin, apart from the symptoms, also involves the gastrointestinal system. So it's not just the mucous membrane swelling of the mouth and upper airway. There's also involvement of the intestine. So in some cases, they could present with severe abdominal pain, even if one of those medical causes of acute abdomen. So just to add that, the patient could have GI manifestations in certain of angioedema.
Yeah, yeah, thank you.
Thanks so much, Dr. Temi, for that beautiful addition. Okay, so Dr. Ifoma is adding urticaria. Yeah, there are like hives or wheels. Angioedema is a swelling that also involves Dr. Ede. Okay, so in absence of this, I'll hand over to our teachers. Margaret Isabel.
Oh, thank you. Thank you, Dr. Kele. Thank you, Dr. Aliyu. Thank you so much. I just thank you so much for the presentation. I appreciate your effort. I just want to, it was a good presentation, but the question you ran through the question, you didn't really answer it in details, you dwelled more on the after presentation. We really encourage that you go to town with the answers. Then when it comes to the presentation, just give us a summary. So for others, please just help us be more elaborate. I don't know if you talked about such patients. Can you go to the question again, please? Yes. Talked about I don't know if by any chance you talked about discharging your patients in that, is there a D to the question? Because even C, when you are talking about step-by-step management of your diagnosis. No. I mean, after C, was there a D question?
No, there wasn't.
So when that step-by-step management, so when you're done with the step-by-step management, you're going to discharge your patient now. I don't know if you mentioned anything about that.
No, I didn't.
And then you talk about how you care for how long you're supposed to keep your patient. When you are discharging your patient, how you're going to, what the advice, because generally the advice, if the patient is fine, you still observe for at least 24 hours, at least 24 hours, not allow them go. Then you counsel them, take note, let them know the drugs that was implicated, another cross-reactant. They should avoid such drugs in the future, and all that cross-reactant of that particular drug should be avoided also.
Okay. All
Then
right.
you give them a short appointment to come back. So this is quite important. But I could say, Jack, you already presenting Nigeria. I was like, what happened?
All right. I will add that after this slide now.
But it was a wonderful presentation. We just want more elaborate answers to the question so that those that needs it, they will have options. So in case we might have 100, might not. It's almost impossible to remember 100. Some people remember 100, but sometimes if it's 80, it's still fine. 90 is still fine. So that let's have a lot of information for people to have access to. So whatever happens, they will still be fine. But thank you so much. It was quite wonderful. We appreciate your effort. And one thing I'm also stating is the fact that Dr. Ekele mentioned that you volunteered to answer a question. I must appreciate you for that. These are things to encourage. Thank you so much. Thank you. When people run from questions, you are volunteering to answer questions. So we appreciate such attitude. Thank you.
Thank you.
I don't know if any of our sis, you're welcome, sis. I don't know if any of our sis have any comments. If Cookie, Remigos, Chitu, Fatima, Dahatu, Okopi, Ata, Yahaya, Success. I know I said Success. I don't know, Fatima. I don't know if anyone have any comments, any addition.
Hello, Dr. Christopher.
Yes, sir.
Yeah, thank you for the presentation. I just wanted to commend the presenter. Thank you for the effort. You've said most of what I wanted to say. But the difference between angioedema and urticaria, I don't know, sometimes people see it as a spectrum, okay? That it can start with urticaria, then progress to angioedema, even though I'm sure there's no hard and fast rule about it. But just as everybody has said, angioedema seems to talk more about the swelling. However, it's also possible to have urticaria even in the setting of angioedema. So if you want to make diagnosis, you will not be seeing urticaria and angioedema. It's still angioedema, even though there are some the urticaria is there too. But the urticaria is more of the skin manifestation, and the angioedema is more of the swelling. However, even when somebody has angioedema, they can also have the skin lesions. I think that's just what I wanted to point out. Thank you.
Thank you, sir. Thank you. Thank you. Any other comments from our teachers?
No comment.
Okay.
It's a wonderful presentation.
Thank you. Thank you. Dr. Farida, thank you so much. Thank you. For all. We say thank you. Appreciate your efforts. Tekele, thank you. We can move over to the next presenter.
All right, ma'am. Thank you so much. Dr. Ologu, please come share your slide.
Please, can you see my slide?
I can see it. Thank you. Okay, so you have 10 minutes.
Thank you, facilitators, my teachers and colleagues. I'm Dr. Ologu Christiana Chinyere. I'll be presenting practice question 1B, West Africa College of Physicians, October 2022. The question reads thus: a 55-year-old male with a history of fever who was not seen by his colleagues for days was found unconscious at home. He was brought into the emergency with altered sensorium and 2 focal seizures of his right extremities. He had fever of 38.5 degrees Celsius, blood pressure 90/54 millimeter mercury, pulse rate 124 beats per minute, respiratory rate 24 cycles per minute. A, list 3 differential diagnoses and give reasons. B, mention 5 relevant investigations in the emergency unit. 3 differentials will include 1, cerebral abscess because of history of fever, focal seizures, and altered sensorium. 2, diabetic emergency because of history of altered sensorium, focal seizures, hypertension, and signs of infection, which could be the precipitating event. 3, stroke because of altered sensorium and focal seizures. Another differential could be sepsis because this patient presented with fever, tachycardia, tachypnea, hypotension, and altered sensorium. B, mention 5 relevant investigations in the emergency unit. 1 would be a random plasma glucose, which would help to confirm one of my differentials of diabetic emergency. Random blood sugar is another investigation to be done. This will help to confirm if there's evidence of infection that could be a trigger to this diabetic emergency. 3, urinalysis. This will also help to find if there's any focus of the infection, and if there's diabetic emergency, to ascertain if a patient has ketone bodies, significant ketone bodies in the urine. 4 will be a brain CT scan. This will help to rule out any space-occupying lesions like the cerebral abscess, which is one of my differentials. It will also help to confirm if this patient is having any has stroke or other cerebrovascular problems. Another investigation will be a blood culture that will help to culture the organism that's responsible for the infection. Investigations later shown WBC of 20,000, neutrophils 86%, potassium 3 millimoles per liter, sodium 131 millimoles per liter, chloride 95 millimoles per liter, bicarbonate 17 millimoles per liter. Urinalysis showed trace ketone, leukocytes, and nitrites were positive. Lactate 4.5 millimoles per liter, the reference range 0.5 to 1.55. Urea elevated, creatinine is also elevated, random blood sugar 38.8 millimoles per liter, cranial CT is normal, pH is 7.34, partial pressure of oxygen is 78 millimeter mercury. C, what is your final diagnosis, and what in the above findings supports it? D, outline your management. The final diagnosis is hyperglycemic hyperosmolar state precipitated by sepsis, focus, urogenital system. and complicated with shock and renal impairment. Findings supporting this diagnosis include markedly elevated blood pressure of 38.8 millimoles per liter, which is in keeping with HHS, where the blood sugar has to be between 33.3 millimoles per liter to about 66.6 millimoles per liter. This patient also had trace ketone that is more in keeping with HHS compared to DK, where you have significant ketones up to more than 2 pluses. PHS greater than 7.3, more in keeping with HHS. In DKA, pH is less than 7.3. Bicarbonate here is 17 millimoles per liter, more in keeping with HHS. In DK, you have less than 50 millimoles per liter bicarbonate. Blood pressure is low, showing that patient must have lost so much fluid. Patient has elevated urea creatinine, fever, WBC of 20,000, leukocyte and nitrite positive, which shows that there is an ongoing infection that could have precipitated this. They outline your management or have to check patient's airway to ensure they are patent, check for breathing. If the patient is breathing, patient may need to be given oxygen. Then I will secure an IV access, admit this patient into the hospital, preferably the ICU unit, where patients will need benefit from frequent monitoring. Fluid replacement. Patient will be given 2 to 3 liters of IV fluid, 0.9% normal saline. I'll use lactated ringas lactate over the first 1 to 3 hours at the rate of 10 to 20 mL per kg per hour. After this, I'll evaluate this patient to check for the corrected sodium. If the corrected sodium is now less than, if corrected sodium is less than 135 millimoles per liter, then I'll move this patient over to 0.45% normal saline at 250 to 500 mL per minute. However, if the corrected sodium is less than 135, corrected sodium is less than 135, then I will continue with 0.9% normal saline until the corrected sodium is within normal range or is elevated. Then I'll change the patient over to 5% glucose in 0.45% saline or lactated ringas lactate at the rate of 150 to 250 ml per hour. That is when the blood sugar has come down to 250 milligrams per DL. I'll correct patient's potassium. Here, potassium level is 3 millimoles per liter. Because the potassium level is 3 millimoles per liter, I'll correct potassium first before commencing an insulin therapy. And I will give 40 to 80 milli equivalent per liter of potassium before the commencement of insulin therapy. This is because if insulin therapy is commenced before potassium, with this low potassium, then more potassium will be moved into the cells, and this will worsen the hypokalemia that the patient is having already. Insulin administration is another line of management, and I'll start this patient on short-acting regular insulin, IV, at 0.1 unit per kg as a bolus. Then I will follow it up with 0.1 units per kg per hour IV insulin by continuous IV infusion via a separate IV access from that of the IV fluid. If there's no response in 2 to 4 hours, then I'll increase the insulin dose by 2 to 3-fold. I'll decrease the insulin infusion to 0.02 to 0.1 units per kg per hour when patient is stable and blood sugar is ranging between 150 to 200 milligrams per DL and hyperosmolarity has equally resolved. Then I'll administer long-acting insulin as soon as patient is eating, and then I will allow a period of overlap between 2 to 4 hours in the insulin infusion and subcutaneous long-acting insulin injection. I'll treat this patient for infection because we have evidence of infection. And I'll use broad spectrum antibiotics while waiting for culture. I must have sent for culture of blood and urine to ascertain the organism responsible for this infection and the sensitivity pattern. I'll monitor blood glucose every 1 to 2 hours. And then I also monitor patients' electrolytes and iron gap every 4 hours. For the first 24 hours. I monitor her pulse, respiration, mental status, fluid intake, and output every 1 to 4 hours. I give this patient anticonvulsants because the patient has had repeated episodes of seizures. The patient will benefit from a benzodiazepine. I also give antibiotics to take care of the elevated temperature of 38.5. Patient will also receive anticoagulant for DVT prophylaxis. And I'll monitor patient's serum electrolyte urea creatinine to see if there'll be worsening azotemia. If there's worsening azotemia, patient would need to be seen by the nephrologist, and if patient merits the criteria for dialysis, will also receive dialysis. I'll give patient diabetic education when she is stable and is about to be discharged. This is to foster recurrent episodes of HHS. Patient will also benefit from the services of a certified diabetic educator if they're available. I want to give a short review on hyperglycemic hyperosmolar states. This is the outline. Introduction. HHS is a clinical condition that arises from a complication of DM. It is a metabolic emergency characterized by hyperglycemia, hyperosmolarity, and dehydration without significant ketosis, and is most commonly seen in type 2 diabetes. It was first described by von Frerich and Dreshfield in 1880. This clinical condition was formerly called non-ketotic hyperglycemic coma, hyperosmolar hyperglycemic non-ketotic syndrome, and hyperosmolar non-ketotic coma. The hallmark of HHS is profound dehydration, marked hyperglycemia, and often some degree of neurological impairment with mild or no ketosis. There's common risk factors, triggers that trigger HHS, uncontrolled diabetes or undiagnosed DM, type 2 DM patients. Advanced age, infection, like we see in this index patient had a UTI. Pneumonia, sepsis, cellulitis can trigger HHS. Medications also, like beta blockers, can be triggers to HHS. Vascular events such as cerebrovascular accident, myocardial infarction, alcohol abuse, endocrinological disorders like acromegaly.
You have 1 more minute.
Okay. Pathophysiology. The basic underlying mechanism of HHS is a relative reduction in effective circulating insulin with concomitant rise in counter-regulatory hormones, which is usually exacerbated by inadequate fluid intake. The amount of insulin in circulation is enough to prevent acidosis and formation of ketone bodies, but not enough to facilitate transportation of all the glucose into the cells. Therefore, insulin deficiency increases hepatic gluconeogenesis and glucogenolysis and impairs utilization of insulin of glucose by the skeletal muscles. The hyperglycemia that will not induce an osmotic diuresis with simultaneous loss of electrolytes in urine. This usually is exacerbated by inadequate fluid intake, leading to severe dehydration and hyperosmolarity. Severe dehydration will lead to hypotension, which will lead to hypoperfusion of the vital organs, including the kidneys, which will now lead to oliguria and impaired renal glucose excretion, and this will exacerbate the hyperglycemia. Hyperglycemia, hyposmolarity, and severe dehydration will then lead to the signs and symptoms of HHS. This is just a picture showing what happens in decreased glucose utilization, increased gluconeogenesis, increased glycogenolysis, all will lead to hyperglycemia. And then this will lead to glycosuria, osmotic diuresis, loss of water and electrolytes, severe dehydration because of this, leading to hyperosmolarity and impaired kidney function, which will all lead to HHS. Let me just talk about the initial laboratory tests of a patient suspected of HHS includes this. I mentioned about corrected sodium. Let us look at this. The it's showing, the table is showing differences between DKA and HHS. Between DKA and HHS. This is for DKA. Glucose is usually between 13.9 to 33.3 millimoles per liter, while in HHS is up to 33.3 to 66.6 millimoles per liter. That is greater than 600 to about 1,200 milligram per DL. Sodium is also low in DKA, but within normal ranging in HHS. However, they could also be hyponatremia because they increase the hyperglycemia, the severe hyperglycemia draws water into the intravascular space and then reduces the concentration of the sodium and leads to pseudo hyponatremia. Potassium could be elevated in DKA, normal in HHS, and then the osmolarity in DKA is between 300 to 320 milliosmol per mil, while in HHS it is 330 to about 380, essentially greater than 320. Serum ketones and urine ketones is usually elevated in DK up to 4 pluses, while in HHS is either absent or just trace or 1 plus. Serum beta hydroxybutyrate is greater than 2.5 in DKA, but less than 1.0 in HHS. The serum bicarbonate is less than 18. In most literature, they will tell you it's less than 15, and then greater than 15 in HHS. Arterial pH is usually between 6.8 to 7.3 in DKA, greater than 7.3 in HHS. Then arterial PCO2 is 20 to 30 in DKA, normal in HHS. Then anion gap is elevated in DKA. However, they could still be slightly elevated than anion gap in HHS. Treatment, I've talked about the treatment, which is the main goals include to vigorously rehydrate this patient while maintaining electrolyte homeostasis, to correct hyperglycemia, to treat underlying disease, to monitor and assist cardiovascular, pulmonary, renal, and central nervous system, ABC, fluid replacement, insulin therapy. We have talked about the management, so insulin therapy, potassium replacement. When if potassium is less than the initial potassium level, if it is less than 5.0 to 5.2 milliequivalent per liter, you give 20 to 30 milliequivalent per liter of potassium infusion. But if it is less than 3.5 milliequivalent per liter, then 40 to 80 milliequivalent of potassium is added to each liter of fluid. If initial serum potassium level is greater than 5.2, patient will not be given insulin. Patient will not be given potassium. Potassium will not be corrected if the initial potassium level is greater than 5.2. Then treat underlying infection, and then monitor this patient. Okay. Thank you so much.
Well, thank you so much, Lucian, for that beautiful presentation. Now we'll take comments and questions from the participants first, and then our teachers will come in thereafter. Okay, so then let's keep the things coming on the chat. Okay, so we have some comment. That's from Dr. Olalekan. Good morning. Thanks for the presentation. Acute bacterial meningitis or acute bacterial encephalitis should be added as an important differential diagnosis. Well done. Okay. Dr. Chris Ade says, thanks for a good presentation. Please, you did not comment about the obvious lactic acidosis in your management. Okay, so Dr. Aminu Bashir says, thanks for the presentation. Patients may not necessarily require anticonvulsants. The seizure is likely to be from multiple inciting factors, including severe dehydration, dyselectrolytemia, severe hyperglycemia or sepsis, which should be ameliorated by treating those above, except the patient has background seizure disorder. Thank you for the comments. Dr. Yahya Mohammed says, thanks for the good presentation. I think meningoencephalitis should be one of the most strong differentials, even more than the cerebral abscess. What's the serum osmolality in the patients? Did you add ABG, ECG? They're important investigations to add. You can add brain MRI to the brain CT scan you mentioned, since you are entertaining brain abscess. more so meningoencephalitis. Thank you, Dr. Yaya. And every other person is saying thanks, Dr. Idol, Dr. Anthony, Dr. Ugo. Okay, Chief, do you want to make some comments? Do you want to react?
Okay. Okay, the lactic acidosis of 4.5 in this patient is true. This could come from the sepsis that the patient is having, and additionally, if patients that have HHS have severe hyperglycemia and dehydration, also because of poor perfusion to the tissues, there's production of lactic acid, and so the lactic acid may increase to some extent in HHS. But you may not need anti-seizure. Yes, the thing is that this patient has had repeated episodes of seizure. So to forestall another seizure before the hyperglycemia comes down and patient is well rehydrated and the infection comes down, patient might just need a short dose of benzodiazepam like diazepam. Not actually that this patient will continue on anti-seizure for a long period. Yes, the meningoencephalitis is another differential, but I was just considering because they said 3 differentials. So, but those are other differentials that could come, that could be the differentials for this question. Okay. I can't remember any question. Is there any other question I'm missing, please?
No. No, okay, then the others are just additions. Should add ABG, ECG to the presentation. All right, thank you so much for the beautiful presentation. Okay, so Dr. Yusuf is suggesting the final diagnosis should be HHS precipitated by sepsis, focus UGS, complicated by septic shock and AKI. If BP doesn't improve on initial fluid resuscitation, inotropic agents must be used because of the septic shock. Thank you so much, Dr. Yusuf. So Chief, you just take note of all the comments. Dr. Jamila Bashir says, thank you for the wonderful presentation. Potassium replacement should start within the range of 5 to 5.2 or 5.4, according to some authors. The less than sign in your slide should be removed. Thank you. Okay, so just take note of all the comments, Dr. Chinyere.
Okay.
Okay, so if you want to make a comment, you can raise your electronic hands. Okay, bye. Overall, it was a nice presentation. Thank you so much. Okay, so there are no more comments on the chat. Okay, so at this point, I think I'll hand over to our teachers. Christabel.
Oh, thank you, Dr. Ekele. Thank you, Dr. Ologo. That was quite a wonderful presentation. Thank you so much. I think lactic acidosis should be one of your differentials. Thank you. I don't know if our other teachers have any comments. I must appreciate the person that brought up that lactic acidosis. Please, God bless you for us. Thank you so much. Chief Cookie, Chitu, Amigos, Chibansis in class success.
Chair, to the question.
Okay. Any comments? Fatima, Dahatu, Ataya. Yes, sir.
My first comment is that I'm not happy with the endocrinology people in this. I'm not hearing them. They should talk. Eh? They're supposed to talk because we want endocrinology represents on this floor. We don't want cardiology and nephrology to be the ones that are moving the stuff. Chief Bansi, what's happening to your people?
Chris hand is up. Like Chris want to redeem them.
Very good. So please go ahead.
Dr. Chris, go ahead, please. Dr. Christian, you are still muted. We can't hear you.
Hello, please, can I be heard?
Yes, you can be heard now.
Okay. Thank you. I was trying to unmute. I was having problems. Thank you. Okay. Thank you very much. Excellent presentation. A few additions. Regarding HHS, because the insulin deficiency is not as severe as what happens in DKA. They usually require less insulin. So compared to the DKA, where we would give about 0.1 units per kilogram body weight of insulin, in HHS, you need about half of that. So you would do 0.05 units per kilogram body weight. But even before you initiate the insulin, you should focus on the fluids first, especially for this patient who has hypokalemia ab initio. If you start insulin, you're going to worsen the hypokalemia. And moreover, the initial fluid resuscitation is so important because it really improves the osmolarity in addition to correcting the fluid deficit. So what happens is that usually in the first 1 or 2 hours, you should hold on with your insulin, especially in the setting of hypokalemia in this patient. And then you would really push the fluid in. What also happens is that the hyponatremia that this patient had, with the fluid resuscitation, it can correct, because as the osmolarity drops, what would happen is that you would move fluid back into the intracellular space, and then this dilutional hyponatremia that you see would also correct without you necessarily having to worry about giving any form of sodium to bring the sodium up. And then also I think one person said, I was also going to comment about the anticonvulsants that he said you would take. This is an acute symptomatic seizure, and it's obviously because of the severe hyperglycemia as well as the other factors. This patient had a fever and a whole lot of electrolyte disturbances. So this seizure is an acute symptomatic seizure. Once you deal with these underlying problems, it will correct. There will be no need to give the anticonvulsant. So I think I'll just pause here and allow other people to come in. If I have to come back, I'll come back. Thank you very much.
Thank you so much, Dr. Christian. I appreciate your contribution. Any more comments? Any more comments? Okay, thank you so much. Any other comment from any of our teachers? Okay, it's fine. Thank you, thank you. Thank you so much, everyone. I appreciate Dr. Olobu. Once again, we thank you. Dr. Christian, thank you for your comments. I appreciate that. Then